Good afternoon, everyone, and welcome to this webinar. I'm Dr. Parikshit. I'm the Joint Secretary of FOXI, and I'm a consultant obstetrician and gynecologist practicing in Mumbai. Right at the outset, let me begin by wishing all of us all the very best in this battle against Corona. That's all that we've been thinking about in the last 1 week or 10 days, and rightly so. But just to take your minds off that very grim aspect of life, we are here with an educational webinar on preterm pre-labor rupture of membranes and its conservative management. Let me thank Dr. Alpesh Gandhi, the President FOXI, for this initiative and for starting this concept of distance and remote learning. My thanks to Gynext Division of Zydus for their support, and DocMode for providing the platform for all of us to be together and have this knowledge sharing experience. So we all know that the fetal membranes form by the fusion of the amnion and the chorion, and this gives rise to the amniotic sac. This amniotic sac is really the baby's protective cocoon. It is sterile and it's filled with fluid. The fluid is very important for the fetus as it is a source of nourishment and a means of development of the vital organs like the lungs. When we are discussing this topic of preterm pre-labor rupture of membranes, it's important to first completely identify, define, and state the scope of what we are going to discuss. So the important terminologies in this topic: first, preterm gestation. That means between 24 to 37 weeks. If the period of pregnancy is less than 24 weeks, this is a pre-viable pregnancy or a miscarriage. In this definition of 24 to 37 weeks, between 24 to 26 completed weeks of pregnancy is what we call the peri-viable or the borderline gestation period. And at the other extreme of this period, 34 to 37 weeks are the time of pregnancy, which are called the near-term gestations. Now, having said this, let me go into the importance of these two extremes, the less than 24 or 24 to 26 and then the 34 to 37. The less than 24, the pre-viable gestations, are typically ones where there's very little scope for conservative management. 24 to 26 is a very, very difficult period for decision making because here there are a lot of variables, especially those related to infrastructure. And the importance of the 34 to 37 week gestation is that this is a near-term fetus and the outcomes in terms of the fetal maturity are almost the same, nearly the same as a term gestation. The next aspect is pre-labor. It has to be before the onset of features of labor such as uterine contractions or a demonstration of the cervical change. Rupture of membranes, when we use that term, the context is a typical clinical situation of a low rupture and not a high leak that one might get post an amniocentesis or a similar intrauterine procedure. So this is the definition and scope of what we are going to discuss. The question is, why are we talking about this? Why is PPROM an important clinical entity? We all know that about 1 in 10 deliveries in the world is a preterm birth, and the single largest contributor overall to neonatal mortality and morbidity is the preterm birth of an infant. Now, amongst this group of preterm births, about a third are because of a preterm pre-labor rupture of membranes. And it is important to understand that the PPROM compounds the problems of prematurity to the fetus with the added morbidity of sepsis. There is also a higher risk of adverse maternal outcomes in PPROM than in other preterm births. So this makes PPROM an important clinical entity that we have to focus on a little more closely. If we look at the etiology and course of preterm pre-labor rupture of membranes, we have to appreciate that it's usually the onset of an inflammatory process or processes which lead to this event. One of the inciting factors has been named as bacterial vaginosis and having an abnormal vaginal flora. Due to these changes in the vaginal flora, there is a generation of cytokines, and these cytokines, interleukins, and other biomolecules lead to a weakening of the membranes, ultimately leading to a rupture. Now, this needs to be differentiated in terms of the etiology and contrasted from preterm labor, where mechanical, anatomical, and cervical factors will predominate as the etiological or inciting factors for the onset of preterm labor. Of course, there could be an element of inflammatory and infectious processes in preterm labor as well, but it's the degree which is going to set the etiology of preterm labor and preterm PROM apart. Most women, nearly 3/4, will deliver in 7 days. The latent phase will be approximately 24 to 48 hours when one is closer to term, and if it's remote from term, then the latent phase can be longer. And accordingly, risk of infection is higher with an earlier gestational age and a longer latency phase. So how does one make the diagnosis? Usually, a good history is very, very telling when it comes to the diagnosis of a preterm pre-labor rupture of membranes. Now, often women will say something like they have some wetness down below, or they are noticing a discharge, or they might actually be able to assess that it's a urinary incontinence. But what we are looking for when we are looking at the history of a PROM is a gush of fluid, or the woman says that she woke up in a pool of fluid on the bed, or she started noticing that even though there was no gush, there was fluid that ran down the legs. And these are the ones which will give you a rough quantification that there is enough amount of fluid that is appreciable and that is suggestive of a rupture of membranes. A speculum examination only should be carried out at this stage. A Cusco speculum is quite useful, and one should be prepared with testing papers in case there is clinical doubt. Of course, sometimes it's very obvious. The vulva and the vaginal examination will reveal that there is enough fluid and there's no need for these testing papers. But if there is a doubt, if there is a concern that the diagnosis is not very certain, these testing papers become useful. And the principle of these testing papers is the pH of the various types of fluid that we find in the vagina. The principles that we have to follow when performing these tests are that it should be a sterile, uncontaminated sample of fluid which is tested with that particular paper. We have to acknowledge that there can be some false positives. Quantification as to the exact pH is very difficult because we don't have those kind of bedside techniques. Usually the paper tests can differentiate that this is acidic and this is basic. So if we want to understand what would be the results of pH testing, one should acknowledge that there is a difference in the various types of vaginal fluid that one may find. What we are looking for to establish the diagnosis of a rupture of membranes is amniotic fluid. And typically the pH of amniotic fluid is somewhere around 7.8 to 8. This makes amniotic fluid alkaline or basic. Now, the presence of blood, whether it is fresh or altered, will make the same color change on the paper strip. So, the presence of blood leads to a false positive result with amniotic fluid getting confused. If we look at the other vaginal fluids, that is, a normal vaginal fluid is acidic. The pH is supposed to be around 3.8 to 4.4. If the woman has bacterial vaginosis, it is a little more alkaline than the typical vaginal fluid, but still it falls into the acidic range. Urine is nearly neutral, may be slightly acidic or slightly alkaline, depending on a number of factors, including diet, the type of medications, etc. So having understood that amniotic fluid is basic or alkaline, let's look at the various paper testing options that we have. Of course, there is litmus paper, which is the one which we've all used as children in chemistry labs. And then there is nitrazine paper, which is also useful. Nowadays, nitrazine paper loaded gloves are available where the thumb and the index finger have particular added elements. So the index finger has a very small, tiny strip of gauze, and the thumb has the nitrazine paper. So when an examination is performed, then that gauze can be touched to the nitrazine paper and this can give us a reading. Now, how does one remember which color changes to what? So very easy. I always remember that blue is basic. Remember blue jeans. That's the most basic kind of thing that you can wear. So blue is basic. When you find that the litmus paper turns blue, that means you are dealing with an alkaline environment. And then, of course, the opposite follows, that the red is acidic. So what should be the initial evaluation of this woman who has presented with a preterm pre-labor rupture of membranes? The first thing that we need to do is establish the correct gestational age. Check this again. Check the last menstrual period, check the first available ultrasound, preferably a first trimester scan, and establish what is the gestational age. Because this plays a very important role in terms of counseling, prognosis, the type of interventions that you are going to offer. The next question that we need to ask ourselves is, has labor begun or is it imminent? Then automatically this woman should not be managed in the typical conservative fashion of a preterm pre-labor rupture of membranes. The next decision-making part of the evaluation is to ask whether early intervention is indicated for the mother if she has some medical issues or if there are features of chorioamnionitis and sepsis. Early intervention could also be indicated for the fetus in case of a cord prolapse, antepartum hemorrhage, if there is evidence of fetal infection, or if there are abnormal fetal well-being tests like an electronic fetal monitoring. And the last part of the evaluation should include fetal presentation, because this will help us to plan and to think about how to deliver this baby in case conservatism has to be abandoned. How does one look for infection? Well, clinically, there would be fever, chills or rigors, and flu-like symptoms. Now, I know that in today's day and age, saying flu-like is an invitation for all sorts of questions related to COVID-19. But of course, we are not talking about that. We are talking about the typical flu-like symptoms that one experiences. There could be tachycardia, and at a later point, there will be fever as well. The CBC and the CRP will be raised when there is infection, but there could be false results because pregnancy itself induces leukocytosis. The urine analysis should be done. Whether taking a high vaginal swab in this situation is useful or not is something that's quite controversial. Typically, the results from a high vaginal swab are available only after 48 to 72 hours, by which time either the woman has delivered or we have already initiated the basic antibiotic therapy. So what do we do with those results is a question that does not have a very clear answer. And lastly, ultrasound. Yes, ultrasound in looking for fetal infection, because in addition to the routine use of ultrasound, that is establishing the fact that there is fetal cardiac activity, the presentation, the rough fetal weight, and an assessment of amniotic fluid index, biophysical profile correlates quite well with the evidence of fetal infection in these kind of circumstances. So a low biophysical score in this kind of a situation will not point towards asphyxia or hypoxia, it will point towards fetal infection. Electronic fetal monitoring, what we see is a loss of variability if there is infection, and if there is an occult cord compression, then one might actually see decelerations. Now, gestational age needs to be taken into account when one offers this test and interprets it. The electronic fetal monitoring changes at different times of the pregnancy. When one is remote from term, one does not expect that variability will be good. Accelerations also are rare. But in any case, an electronic fetal monitoring should be offered. The importance here is in case there is a non-reactive test after a reactive test earlier. So for example, you've done the test at the time of presentation and it is fine, but after 12 hours or the next day, if the test is non-reactive, then that is highly suspicious. It tells you that there is a possibility that the fetal infection is setting in, and this could be an indication to stop the conservative management. So these are just examples. Here's the presentation. Here's the electronic fetal monitoring trace at presentation. It kind of, the variability started slowing down and there was a small deceleration, but after some time it became a much wider deceleration and the variability reduced much further. So this is the kind of change that one might see when one is talking about the onset of fetal infection. So what management issues are there? The first question is, of course, should we intervene and not go at all for a conservative approach? This is important to identify right at the outset. And then there are a number of drugs such as steroids, antibiotics, tocolysis, and magnesium sulfate that we should consider. This time that the woman has from the presentation onwards should be used carefully for counseling the woman and her partner and drawing up a delivery plan. This is important to be reviewed because the circumstances have changed quite drastically now. The woman was expecting to be delivered in a particular setup where a neonatal care facility may or may not be available. But if she is in a situation where preterm delivery is likely, say at 30 or 32 weeks, and the site where she is being cared for at present does not have the adequate neonatal facilities, this is the time that should be utilized for planning, counseling, and in utero transfer to the best place, to a tertiary care facility where both the mother as well as the baby who is going to come out in a few hours or days can be looked after in the best possible way. So it's a complex kind of a situation in terms of the decision making. What are we looking at? In terms of infrastructure, we need to look at the neonatal intensive care availability at a particular setup. What is the usual outcome at a particular gestation? Are beds available? Is a ventilator available? Is the neonatologist confident about handling this kind of a preterm delivery? What are the parental wishes? What do they wish to do in terms of where they want to seek care in this altered circumstances? And of course, what are the biological variables? How is the fetus doing? What is the gestational age? And is the mother free of sepsis or not? So putting all this together is what the obstetrician has to do, and then come up with whether this pregnancy can be conserved or whether it's time to go ahead and deliver the baby. So the decision making in PPROM rests between reasons to wait and reasons to intervene. The reasons to wait are fairly obvious. One wants a more mature fetus. We don't want to particularly deliver a 30 or a 32-week fetus. We would really appreciate if the fetus could stay in there for another couple of weeks. If not that, then at least until the time that corticosteroids that have been administered at the presentation have had enough time to act, and an adequate antibiotic cover also has been established. We would also like to wait if the mother is not in the optimal infrastructure to have the delivery, so to effect in utero transfer. And then, of course, there is also the argument to wait that let nature take its course. It is a much better decision maker than most obstetricians, and the presentation will change when the circumstances change, and when they do, that's the time to intervene. What would be the reasons to intervene early? If labor has started and it cannot be stopped, if there are acute complications either to the mother or the fetus, which I alluded to earlier, maternal in terms of sepsis, antepartum hemorrhage, and for the fetus in terms of cord compression or abnormal fetal well-being tests, one would also like to intervene if there is a suspicion of infection, or one would like to avoid infection by an early intervention and prevent fetal complications, which can also occur when one is in a conservative approach. We all know that the biggest determinant of the survival of the preterm baby is the gestational age at which the child is born. As the gestational age advances, the survival improves, mortality falls, and so does almost every morbidity that is related to preterm births, especially respiratory distress and necrotizing enterocolitis. So, visiting the management issues again in terms of the interventions during the conservative management, the first one that we have on our list is corticosteroids. We are all familiar with the regimes and the timing when corticosteroids should be administered. 24 to 34, or some authorities say 37 weeks is the time when we should give corticosteroids. The optimal treatment delivery interval is 24 hours, but less than 7 days. What are the benefits? Manifold. Right from a reduction in the neonatal mortality to improving lung function and reducing RDS, reducing intraventricular hemorrhages and periventricular leukomalacia, and there is less necrotizing enterocolitis, retinopathy of prematurity, and platelet dysfunction as well in preterm babies who have received an adequate course of corticosteroids. Which agent should use? Well, betamethasone is preferred over dexamethasone. They are both equivalent in terms of preventing respiratory distress, but betamethasone has a slight edge when it comes to the cortical effects. So, if available, betamethasone is the drug of choice. Failing that, dexamethasone is equally acceptable as well. Oral agents like cortisol and prednisolone do not cross the placenta adequately and should not be used. This is the standard regime: betamethasone 2 doses 12 milligrams intramuscular 24 hours apart, or dexamethasone 4 doses 6 milligrams 6 hours apart. Oral therapy, as I said earlier, is not indicated. It is associated with a greater incidence of neonatal sepsis and intraventricular hemorrhage. There are concerns about administering corticosteroids when there is a potential for infection. So, when should we not administer corticosteroids? Only if we suspect systemic infection or clinical chorioamnionitis, or of course, if there is a background of widespread tuberculosis. These are the only reasons when corticosteroids should not be administered. So for the average patient who comes to you at say 30-32 weeks of gestation without any other features except for a rupture of membranes, please go ahead and administer the corticosteroid as is routinely advocated. When are corticosteroids less effective? Well, if it's a multiple pregnancy, if the woman has diabetes, she has an hydropic fetus, or it's a very early pregnancy at the borderline, that's when corticosteroids may be given, but their effect is going to be much lesser than what we would like it to be. What are the problems? Well, there could be a suppression of clinical features of infection, and those women who have a deranged glucose metabolism may have an alteration of the blood sugars, may need a little closer titration of the antihyperglycemics, may need hospitalization if they are on an insulin protocol. And this effect may last for 2 or 3 days before the glucose metabolism returns to normal. When should you repeat corticosteroids? Well, as of what the knowledge says today, there is no benefit of repeating steroids routinely every week as was the practice once upon a time, because there are potential harmful effects on infection, on fetal growth, and on fetal cortical function. Now, fetal cortical function is something that is quite underappreciated because this is not something that we can easily see, but it affects the fetus's ability to fight infection once it is born. So usually we do not repeat steroid doses at all. And observational studies, of course, would naturally be biased because as time goes by and you repeat steroid doses, you would naturally find improving outcomes for the neonate because the gestational period is increasing. The next therapeutic intervention that we can do is administer antibiotics. The rationale here is latency, prophylaxis, or therapy. It increases latency, it allows for the steroids to act. The onset of labor gets delayed just that little bit more. It's a prophylaxis to prevent against infection because now the system is open to the environment. The vaginal flora is free to migrate upwards into the uterus and the upper genital tract. The benefits that have been demonstrated by administering antibiotics are a prolongation of pregnancy and a reduction in major neonatal morbidity. Now, it should be understood that this is preterm, pre-labor rupture of membranes where antibiotic therapy has shown to be useful. This is not standard preterm labor with intact membranes, and neither is it a rupture of membranes at term. So in this very secluded group of women, antibiotic therapy is indicated and it is useful. What's the drug of choice when it comes to antibiotics? The standard regime is to use ampicillin and erythromycin as a combination. We can start with intravenous doses of ampicillin and erythromycin orally, and later on it can be followed up by oral substitutes in case the intravenous is not needed anymore. Amoxicillin and clavulanic acid, particularly the clavulanic acid component, has been associated with a slight increase in the risk of necrotizing enterocolitis according to the Oracle study. and therefore the commonly used amoxiclav combination should be avoided in these situations. Where does tocolysis fit in for the woman who has presented with preterm pre-labor rupture of women? In one word, do not use it routinely. What could be the possible role for tocolysis? Well, if labor starts but steroid action is not completed or in utero transfer has not yet occurred, then for that small window of time, for that short period, one could consider giving tocolysis. But as a routine, tocolysis has no place whatsoever if the membranes have ruptured. In fact, some of the tocolytics, for example, betamimetics, can cause a tachycardia. In sepsis, also there is a tachycardia. What could happen is that this tachycardia, which is a very important vital sign to identify sepsis, could misleadingly be attributed to the betamimetics, and you could miss the diagnosis of sepsis altogether. What are the results in the trials that have been conducted for tocolysis? Well, it does not increase latent phase significantly. It does not reduce serious neonatal morbidity. And tocolysis seems to be of value only to allow steroid action. So for that very, very short and brief period, if you want to tide over a few hours, you may consider tocolysis. Otherwise, there's very little role. In fact, it could harm the situation by its use. One of the more recent interventions that we have started offering women who are delivering preterm, not only in preterm pre-labor rupture of membranes, but in preterm deliveries as a whole, is the use of magnesium sulfate. And the WHO now recommends the use of magnesium sulfate for fetal protection from neurological complications. It's very standard as to how this regime has to be used. We are all absolutely familiar with the standard Pritchard's regime, and this will do perfectly fine when we are talking about using magnesium sulfate for fetal neuroprotection. If the Pritchard's regime cannot be followed for some reason and the facility has services of an infusion pump, then an intravenous infusion of magnesium sulfate at 1 gram per hour can be given until the time of delivery for 24 hours, whichever comes earlier. So it offers a significant neuroprotection, and we have also seen that long-term consequences such as cerebral palsy and neurosensory disability is lesser when magnesium sulfate is administered, especially for women who are delivering before 32 weeks. There is also a lower risk of neonatal death when magnesium sulfate has been administered. Now we go to a subtopic really, which is a little away from the core of what I have been speaking. I have been speaking about preterm pre-labor rupture of membranes, but I thought it's equally important to cover pre-viable PROM as well. Please excuse me for the spelling mistake in pre-viable. Now, in this kind of a situation, delivery versus conservation. Delivery is of course going to be absolutely lethal to the fetus, because there's no way that a fetus at 21 or 22 weeks is going to survive. But the advantage of delivery is that it will minimize maternal morbidity from infection, from adhesion of the placenta and becoming a difficult placental delivery. And of course, there is always that little voice which at the back of the head says, can we consider conservatism? Now, even if conservatism can be done, it still does not guarantee that the fetus will not suffer from the negative effects of the rupture of membranes and oligohydramnios. And we are really running a risk with the maternal outcome in terms of sepsis. So The pre-viable PROM problems are fetal complications like fetal death, neonatal problems of lung hypoplasia, compression deformities, and post-neonatal problems of extreme prematurity and maternal complications of sepsis, hemorrhage, and a retained placenta. Keeping all these in mind, even though there are some desperate and dangerous measures which have been described in these situations, such as the amnio patch, I would strongly urge all of you who are faced with this difficult situation to not consider conservative management. This should be tried only and only in iatrogenic membrane rupture. For example, if a woman has had an amniocentesis for a genetic diagnosis at say 16, 17 weeks, and she presents at 20 weeks with a diagnosis of a rupture of membranes, one might think about conservating her because these have a much better prognosis. They tend to reseal because the opening is very, very small. And here, whether amnio patch is used or not, the results are equally good. So at best, this kind of an intervention can be considered experimental, but the dangers of prolonging the inevitable, the fact that this is an invasive procedure itself, and it can delay or make the onset of sepsis worse, should be acknowledged before taking any such steps. After invasive procedures, the risk of rupture of membranes exists to the tune of 1 to 2%. Here, as I said, there's a high chance of resealing. The fetal survival is nearly 90%, and one can definitely offer a conservative line of management. What about the next pregnancy? Of course, one would expect that the woman and her partner would be concerned, because if there is a preterm birth, either spontaneously or after a rupture of membranes, the worry is that they might have to go through the whole trauma again. They might have to face a very difficult situation in the neonatal care again. So what should we do in subsequent pregnancies which might reduce the risk of preterm birth? Well, aggressively seek and treat vaginal infections early in pregnancy in the first trimester itself. Monitor cervical length. Consider cerclage only if it is indicated by the ultrasound dimensions of the cervix showing a length lesser than 25 millimeter, or if the cervix is showing any of the typical features such as the internal os opening up and the typical Y or the U-shaped internal os is seen on ultrasound. Well, that's the time to consider a cerclage, not routinely at all. And one could consider the use of progesterone because of limited risk that it poses and the fact that it's not an operative intervention. So I would like to thank all of you for your kind attention. There is a message box that you have at the bottom of your screens. Please use that, and let's get set for a good interactive session. So now I'm going to stop the slide sharing, and then I'm going to start taking up the questions as they appear in the Google Sheet, and I look forward to interactions with all of you. Is coming in now. That's great to see. Please keep putting your questions. This will keep getting refreshed, and we'll have a lively discussion in some time as soon as I figure out. Okay, here we go. And minimize. Great. Okay. So the first question comes from Dr. Archana Patil from Aurangabad, and the question is: in case of a PPROM, is it mandatory to avoid transcervical? I presume it should be examination assessment to prevent infection. Yes, I think it's very important to take this protective measure The moment the cervical canal is breached, the infection goes upwards and then there is no stopping it. So if a woman presents herself with either an obvious leak but not in labor, or if you suspect that labor might have started, a good point to start with is a speculum examination. And if the speculum examination makes you suspect that there might be a problem, like she is quite advanced in labor, or if there is antepartum hemorrhage, well, then that's when one could consider a digital examination to assess the cervix manually. Coming to question 2, and that's from Dr. Jyotsna Coelho from Dakshina Kannada. The question is, recurrent PPROM more than 2, how do we manage next pregnancy, I am presuming? Well, I did mention that towards the end of my presentation, that the measures that one needs to take in this kind of a circumstances to prevent the risk of a subsequent event in the current pregnancy would be to seek infections early, treat them aggressively. Once you've done that, then monitor the cervical length. In case there is an ultrasound demonstration of a shortening, then offer her a cerclage if the length goes below 25 millimeters. And if there is such an event, then one should also think about changing the infrastructure in which the woman has been delivered. Now, the next question, number 3, is from Dr. Soumya Gupta from Meerut. I think I know this person, Dr. Soumya, from Twitter, if I'm not mistaken. Nice to catch you over here. The question is 34 to 37 weeks pregnancy. Deliver immediately or conservative management till 37 weeks. Recently, ACOG in their March 2020 issue advised conservative management between 34 to 37 weeks. Well, here we've really got to weigh up the pros and cons of waiting versus delivering. The idea of waiting is that you have a more mature fetus and you need lesser interventions for the woman to go into labor. Consequently, you're going to have more vaginal births. But the problem of waiting is that infection can occur even at that 34 to 37 week kind of gestation. So the thing we need to ask ourselves is, what kind of infrastructure are we working in? If outcomes are nearly the same of a 36 weeker and a 37 weeker, then I would be quite inclined towards delivering this woman rather than waiting. If it's more towards 34 weeks, then I would wait for 24 to 48 hours, let the steroids act, and then initiate labor. Question number 4 is from Dr. Asha Dikshit. The location is mentioned as Delhi, but I think I'm not sure whether it's Delhi or Vapi. What precautions can we take to avoid preterm labor or preterm pre-labor rupture of membranes? I think I addressed this. In a high-risk population, it would be worth looking for vaginal infection, looking at the cervical length, and then offering interventions accordingly. But in the general population, really speaking, there's very little that one can do to completely avoid preterm labor. Going to question number 5, Dr. Farhan from Aurangabad. Can you explain about tocolytic therapy? Yes, Dr. Farhan, in the situation where the membranes have ruptured, tocolytic therapy has a very, very limited role. You would give tocolytic therapy to the woman whom you want to transfer to a tertiary care facility in case you want to do an in utero transfer and you're worried that labor might start, or if labor has started soon after the presentation and you want to delay matters you want to delay the onset of labor for the steroids to act, that's really the only place for tocolytic therapy. So it is a very short time-bound treatment with tocolysis that one may consider in this kind of a scenario of preterm pre-labor rupture of membranes. Coming to question 6, Dr. Ghansham Murlidhar Magar from Aurangabad. Betamethasone is the choice, but it is not available. Dexamethasone. So can dexamethasone be should be used? Yes, yes. If betamethasone is not available, then the next choice is dexamethasone. Dexamethasone and betamethasone are both quite good in terms of preventing respiratory distress in the neonate. The place where betamethasone might have a little advantage is reducing the cortical effects of premature birth, particularly periventricular leukomalacia. That's where betamethasone scores over dexamethasone. But in case betamethasone is not available, then, well, dexamethasone becomes the drug of choice. Question number 7 from Dr. Lokesh Raut from Jharkhand. Any disease which can trigger preterm pre-labor rupture of membranes? Well, it's hard to say whether any particular disease would trigger a rupture of membranes. We know that when there is systemic illness, for example, a high fever or generalized infection due to, say, for example, malaria, we find women going into preterm labor. But that again is a little different from a preterm pre-labor rupture of membranes. So yes, systemic disease, deterioration of the maternal condition for some reason might incline that pregnancy to go towards preterm birth, but not necessarily towards preterm pre-labor rupture of membranes. Welcome, Dr. Parag Biniwale. Question number 8, the ICOG secretary from Pune. The question that he has put forth is a very practical one. Erythromycin is recommended in PPROM, which at times is not available. Have you tried azithromycin? For how long? Yes, absolutely right, Dr. Biniwale. Erythromycin is not always available. It has a 500 milligram 4 times a day kind of a regime. Tolerance tends to be a little poorer. Therefore, many units have used azithromycin 1 gram per day for 5 days in this kind of a situation. It seems to give almost an equivalent response as erythromycin. Unfortunately, there's not too much literature which I can quote to make this recommendation. The official recommendation still remains erythromycin, but in certain situations where it's not available or there is an intolerance of erythromycin, azithromycin seems to be an acceptable alternative. Dr. Pawan has asked question number 9. Dr. Pawan is from Raipur and he asks about the role of amnioceal. I alluded to this towards the end of my presentation. I'm calling it a desperate and a potentially dangerous kind of an intervention. It's desperate because typically these are pre-viable gestations where it is offered. Dangerous because it itself involves an invasive procedure. Sepsis might get triggered, sepsis might worsen, and of course there's really no evidence for us to say that amnioceal gives any type of a beneficial effect in this very dangerous situation. So to answer the question in a single word, role of amnioceal, the answer is no. Question number 10 comes from Dr. Jyoti Ramesh Chandran from Kozhikode. Please repeat dose of DEXA. As what the current state of knowledge lies with, the current recommendation is not to repeat the doses of steroids because whatever effect is there, is going to tide over this situation, and there is no benefit from repeating the dosage of steroids. In fact, it can cause certain negative effects on the fetus, particularly the suppression of fetal cortical function, and therefore one should desist from repeating the dose of dexamethasone. There are certain and only few indications where one might think about doing a repeat of the dexa doses. This situation would be that if a woman has a rupture of membranes or a presentation of preterm labor, say for example at 28 weeks, and you're given the dose of steroids. After this, by some means, 2 weeks or 3 weeks have passed, and then she presents in labor again. Yes, that is the very, very limited place where one could consider using another dose of steroids, or what are called as a rescue dose of steroids. In most other circumstances, no, this is not what is recommended as a standard practice. Dr. Pandit Palaskar, thank you very much for this question from Aurangabad. I have a patient with previous 2 Pprom in spite of cerclage vaginally. Should I consider or give her a lap circle? Thanks, Pandit. This is an extremely difficult question, and I'm sure a laparoscopic surgeon such as yourself would come across these kind of women as a referral. Now, we have to make a distinction between women who have come with preterm, pre-labor rupture of membranes as the initial event, or have they come with preterm contractions. Because if a woman has come with a history of 2 preterm, pre-labor rupture of membranes, then her inciting factor is probably not cervical insufficiency. It's something else. Whereas, yes, if she has come with the typical history or features of cervical insufficiency or unexplained preterm contractions in her previous 2 failed cervical cerclages, yes, that's the woman whom I might consider for doing something different than a vaginal cerclage. Your standard McDonald cerclage may not work. This is a patient on whom the modified vaginal cerclage, or what we typically used to call the Shirodkar cerclage or a laparoscopic cerclage, could be more effective as an intervention. Question number 12 is from Dr. Sandeep Kaur from Hoshiarpur. Sir, the role of tocolysis in PPRN. Dr. Kaur, I just answered this question. Very limited role of tocolysis, just to tide over the few hours that you need for the steroids to act or transfer the woman in utero. Question number 13 from Dr. Milind Kolwalkar from Mapusa. What is the role of fetal fibronectin? Dr. Kolwalkar, fetal fibronectin is a predictive test. It is useful for predicting who has a risk of going into preterm labor. It is not strictly a test for diagnosing preterm pre-labor rupture of membranes or for predicting PPRN. It's a test for predicting preterm births. So that's the place where it might have some role. It's got an excellent negative predictive value. So how should we use this fetal fibronectin test? It's to be used in clinical situations where there is diagnostic doubt about whether this woman is likely to deliver in the next 24 to 48 hours, and it helps to make a decision, because if the fetal fibronectin test is negative, as I said, it's got a great negative predictive value. This is not a woman who is likely to go into preterm labor anytime soon. So you could probably not hospitalize her. You could manage her without tocolysis and giving steroids, etc. and that would help in reducing the number of interventions that one would do when a woman comes with abdominal pain. Question number 14 from Dr. Anaswara K from Calicut. If a patient has no fever, no leukocytosis, and only CRP is elevated from the baseline, should we consider termination? Well, no, I don't think that's the right approach, because we need to keep the entire clinical picture in mind, not only one remote isolated lab parameter. Now, again, this is also going to depend on what's your threshold for offering intervention. If you've got somebody who's at 34 weeks and there is one parameter which is abnormal, I might be interested in taking a decision. But if this is someone who is at 28 or 30 weeks and I am very keen to continue this pregnancy, to offer conservatism to her, then I think I will not really pay that much of heed to an isolated CRP elevation. So the important point is keeping the entire picture, the entire clinical picture in view before making this intervention. Question number 15, Dr. Jyoti C from Chennai. Can you please elaborate the assessment of fetal pulmonary maturity from vaginal pool secretions? Yes, this was a test which was used about a couple of decades back. The vaginal pool fluid was tested for various things, such as the lecithin sphingomyelin ratio, that is the LS ratio, or the levels of elements such as phosphatidyl ethylene or phosphatidyl serine, which at particular levels which are secreted from the fetal lungs would appear in the amniotic fluid, and when that level is reached, then we could say that the fetus is mature. However, in modern obstetric practice, these assessments don't really have much of a role. It's very difficult to obtain these kind of tests in routine day-to-day care. So assessment of fetal pulmonary maturity is left to solely the gestational age, which is firmly established right from the first ultrasound that the woman can have. Question number 16. Oh, I think Dr. Ghanshyam has repeated that question, so I'm going straight forward. Yes, thank you, Dr. Pandit Palaskar, for the compliments. I really enjoyed giving the lecture and the interactions, and it's great to have someone who's a referral unit or a referral physician for these difficult situations. So thanks, Pandit. Dr. Kavita G from Madurai, tocolysis of choice in PPROM. Well, again, if one is going to use tocolysis for that very, very limited time that one needs to tide over for allowing the steroids to act, then the choice would be nifedipine or atosiban. And this actually connects well with Dr. Pandit Palaskar's next question. What is the role of atosiban currently in PPROM? The role of any tocolytic is limited only to tiding over those 24 hours. Beyond that, no tocolytic really has a role. Between nifedipine and atosiban, I think personally my choice would be nifedipine because it's much less expensive and it's easily available, does not require intravenous administration. So that's the reason personally why I would prefer nifedipine over atosiban. Question number 20 from Dr. Suguna M from Bengaluru. Will tocolytics be helpful? I think already answered that one. Let's come to question number 21. Dr. Megh Gupta from Agra. 32 weeks pregnancy with spontaneous pre-prom with GDM. Under evaluation with MNT. I think, okay, that refers to medical nutritional therapy. So what Dr. Gupta wants to clarify is that this is not a woman who is using any anti-hyperglycemics or insulin. Okay, got it. And the liquor is almost drained. How long to wait? Well, here we need to consider the fact that this woman has gestational diabetes, but it is not of the nature which is long-standing and which particularly is going to make her immunocompromised. So I think I would leave this kind of gestational diabetes out of my decision making when it comes to the situation of pre-labor, preterm pre-labor rupture of membranes. I would base my decisions on the fact that the liquor is almost drained, and if there is severe oligohydramnios, then really speaking, there's not much more to wait for. This is a situation where intervention would be required. What we can hope for at best is transferring this woman into a tertiary care institute where facilities for neonatal care are available best. So that's what I would do in this particular situation. Question number 22 is from Dr. Sita Sharma from Amritsar. What is the best mode of delivery in a patient with previous to LSCS, now presented with 21 weeks pregnancy with PPROM? Right. Of course, here, what Dr. Sharma and virtually any physician who would be worried about in terms of delivering this woman would be the risk of uterine rupture when some agents are used to induce labor, and one, of course, has to stop this pregnancy. One has to intervene in some way. So what would be the best intervention? What would be the safest way in which we can deliver this woman? Two choices. One is induction with a mechanical agent such as a Foley's balloon. The advantage of this is no risk from any agents which can cause weakening of the uterine scar. But disadvantage is that you cannot insufflate the space. Consequently, only the mechanical effect on the cervix is going to be there. And the other worry, theoretical, is that the balloon might in fact be a source of sepsis. So that's choice number one. Choice number two is to still use prostaglandins, but not misoprostol. One could consider the dinoprostone gel in these situations, which has a lower risk of uterine rupture. This is a very tricky situation because irrespective of how watchful the physician is going to be, when an induction is done for a previous to LSCS at 21 weeks, there does exist a very small chance, mind you, maybe at about 1 or 2% of the uterus rupturing. Thankfully, the lower segment is not very well formed. That chance is very small as compared to what would happen later on in gestation, but it does exist. So, as one would do, good counseling, watchfulness, and if there is a doubt that there is a rupture of the uterus, then of course an urgent intervention by a laparotomy would be indicated. The other way to look at this problem is that if a woman has had previous to LSCSs and she is at 21 weeks, she probably has, hopefully at least, completed her family, and you would avoid the risk of a uterine rupture completely by doing a laparotomy and delivering the baby. But by no means should it be considered that this is an easier way out than inducing the woman. Even at this gestational age, especially at this gestational age, I should say, it's extremely difficult to do a laparotomy and deliver the baby. There is a risk of uterine injury. There is a risk of injuring the bladder, of extending the uterine incision. So really speaking, it's a tough call. My personal inclination would be towards offering an induction and hoping that things go well and she achieves a vaginal birth. Question number 23 from Vandana Narula from Gurugram. If PPROM is very early in pregnancy. What are the guidelines for how long can we continue the pregnancy? Well, most guidelines, Dr. Narula, for very early, I think one is referring to pre-viable gestation. So before 24 weeks, the weight of evidence really goes towards terminating the pregnancy rather than offering a conservative line of management in these women. One could, of course, give this couple some time, maybe 24 to 48 hours, to kind of, come to terms with this very, very unfortunate event and then initiate the proceedings for an induction to deliver this woman. Question number 24 is from Dr. Indira Rani from Hyderabad. Role of nifedipine. I just answered this, Dr. Indira Rani. Thank you for the question. And it's interesting because a number of people are interested in tocolysis and in prolonging the pregnancy. But this has to be acknowledged, and we need to make sure that we are not prolonging the inevitable. I'm really honored to have Dr. Alpesh Gandhi, the President Foxy, and of course he's asked one of the more tricky parts about the preterm pre-labor rupture of membranes. What if it happens to one of twins and the other bag of membranes seems to be intact? Well, again, this is one of the situations which after having practiced assisted reproduction and taking care of those babies for some time, one has come across. Sir, in this kind of a situation, one would attempt a conservative management, but usually nature takes its course, and one really can't pull on these pregnancies for a very significantly long period to allow complete fetal maturity. At some point, we will have to go in and get the pregnancy delivered. Another question which Dr. Gandhi asks is the role of ophthalmology reference for a woman who has PPROM, and frankly this has left me completely stumped. I wouldn't usually ask for an ophthalmology reference unless there is some other associated problem such as severe hypertension or visual disturbances. So Dr. Gandhi, you will have to type out this answer and give me a clue. Thanks very much. Dr. Pawan from Raipur, role of rescue dose. Yes, I did mention if the latency between the first dose of steroids and the point of delivery is more than 2 weeks, that's the place where, Dr. Pawan, I would consider giving a rescue dose of steroids, not otherwise. Dr. Biniwale, thank you so much for your compliments. Really appreciate your taking out time and being with all of us. Question number 28, Dr. Madhu from Jalandhar. How long can betamethasone be continued? Well, typically, it's the dose of betamethasone, the regime that we use is 6 milligrams of betamethasone, 4 doses every 6 hours, and that's that. After that, there's no role of continuing betamethasone. Dr. Indira Rani from Hyderabad, role of atosiban as a tocolytic. Well, same as any other tocolytic, no better, no worse for tiding over that very, very limited period for crossing those 24 hours of steroid cover. Dr. Pandit Palaskar from Aurangabad, given a choice, which cerclage is better, McDonald's vaginal Shirodkar or lap cerclage? Pandit, I think here one needs to look at the history. I think if you're alluding to that previous situation where someone has come to you with a history of 2 or more failed McDonald's cerclages, if that's the kind of a situation that one is looking at, definitely I wouldn't offer her a McDonald's cerclage again. I would either look at doing a vaginal Shirodkars, which I think I am very competent to handle, or if a vaginal Shirodkars is not doable, that means there's absolutely no cervix that can be got hold of on a vaginal examination. That's when I would consider doing a lap laparoscopic cerclage. But in a more generalized kind of a situation, there's very little to choose from in these three options. Typically, I offer and do a McDonald's cerclage where it is indicated if there's no prior history or no previous failed vaginal cerclages. Dr. Romario Fernandez from Mumbai asks, it is recommended to use magnesium sulfate if delivery is impending before 32 weeks, but if patient is 30 weeks, we give magnesium sulfate and patient continues pregnancy, is it harmful? No, it is not harmful, but if this is the situation that we are in, then one should repeat the dose of magnesium sulfate closer to the point of delivery so that the maximum effect of the magnesium sulfate in terms of neuroprotection can be conferred on the fetus. Question number 32 comes from Dr. Ritu Rishi Grover from Surat. What factors should be considered to decide the mode of delivery? Sometimes the cervical score is poor and the woman, the lady seems to be far away from progressing spontaneously to active labor. Yes, this is a situation that should be individualized. It's not as if cesarean section needs to be done for every woman who comes with a preterm pre-labor rupture of membranes. Having said that, the incidence of cesarean section is going to be high in these circumstances because we are going to get failed inductions. We are going to have situations where fetal compromise may be there and an urgent delivery is necessitated. So these are the situations, and of course the presentation, if the fetus is in a breech presentation, these are all the indications for doing a cesarean section in these circumstances. Dr. Ashu Yadav from Ambala asks, is there any recommendation to give corticosteroids after 34 weeks for any repeat doses? No, there is no indication to give corticosteroids as a repeat dose after 34 weeks. Rescue dose of steroids may be indicated in a very, very limited kind of a situation. Dr. Alpesh Gandhi, oh yes, of course, now I get the question. Ophthalmology reference, not for the mother, but for the neonate. Thank you, sir. Thank you. Thank you very much for the clarification. I got what you're asking. Yes, I agree completely. The neonate should have an ophthalmology reference because these are the risks that the neonate faces from retinopathy of prematurity. And I believe time is up, and I thank every one of you deeply for your involvement and for your active participation. We are closing in on the finish time. Dr. Alpna Kansal from Mumbai, Foxy Focus mentions the use of ampicillin, metronidazole, and amikacin. Yes, they should be used in settings where sepsis is likely or it has set in. That's the protocol I would follow. Dr. Neeraj Bhardwaj from Kolwa, can we give steroids after 34 weeks? We can, but it may have very limited kind of a use in these situations. Dr. Pratna Shah from Aurangabad, post amniocentesis, if patient presents with leaking, which all drugs can be used apart from antibiotics? Well, usually you don't have to do anything. Just wait and watch. These will seal by themselves, and most of the times the pregnancy continues quite uneventfully. Dr. Monica Kesarwani from Ghaziabad, 32 weeks PROM, PIH, BP is 160, 100, Maxal given, Betamethasone given. How to manage? I think here the fact that she has preeclampsia, which is quite severe, and of course you would do all the other investigations to evaluate the preeclampsia, comes into picture, and the decision making is really going to take the precedence of the preeclampsia rather than the PROM. And looking at the clinical picture that you have presented, Dr. Monica, I think this woman is headed for a delivery. Not much that we can do over here. Dr. Prerna Jain from Firozabad, dosing of tocolytics if required other than magnesium sulfate. Well, typically I use nifedipine. The dose is 20 to 30 milligrams as a stat dose, and then you repeat 10 to 20 milligrams every 4 to 6 hours. Do not exceed 62 to 80 milligrams in one day. Dr. Swati from Mumbai, is injection progesterone needed with a previous history of preterm labor and current pregnancy, no ultrasound findings suggestive of reduced cervical length? Again, this is a question which is a little different from what topic we have today. Yes, progesterone with a previous history of preterm labor has been evaluated in trials. Both the injectable as well as the vaginal progesterone has been found to reduce the risk of very premature births. So you may have some births between 34, 37 going to near term, but you will still prevent the critical preterm births of 30 and 32 weeks if you use progesterone in this situation. Dr. Sita Sharma from Amritsar, sir, can we use clindamycin? Yes, you can use clindamycin, not the first line of antibiotic, but yes, you can use it. Dr. Indira Rani from Hyderabad, can we use amoxicillin instead of ampicillin? Yes, equally good, but most trials have used ampicillin. So that's the recommendation. Dr. Neeraj Bhardwaj from Kolwa, can we give steroids after 34 weeks? Answered. Dr. Swati Salikumar from Kottayam, injection progesterone needed throughout pregnancy. I just answered that question. Dr. Swati, thank you very much. Dr. Shikha Saxena from Bareilly, what should be the ideal time after second dose of steroids at 12 hours? Well, the ideal time is to wait for 24 hours, but less than 7 days to effect the delivery. Dr. Aparna Kadha from Gurugram, what is the role of using PPROM detection kits? Yes, these are useful only when there is a diagnostic doubt. So if you have a situation where there is a bit of a confusion whether the membranes are intact or they've ruptured, that's the only place where PPROM detection kits need to be used. Dr. Jyoti Ranjan Mohapatra from Keonjhar, at what interval CRP should be repeated in PROM? Well, blood studies, a CBC and a CRP, roughly at about 72 hours intervals is adequate. Dr. Vandana Jain from Ghaziabad, what is the normal pH of amniotic fluid? Excellent question, right to the basics. The normal pH of amniotic fluid is 7.8 to 8, and that's why amniotic fluid is basic. Therefore, that's what we detect on any sort of pH detection kits or litmus paper or nitrazine paper. Well, some of my residents are here. Hi Sham, how are you? Thanks for watching and logging in. Nice to have you on board. Dr. Vandana Jain, Ghaziabad, already answered that one. Dr. Aryan Tiwari from Sagar, the patient is a primigravida between 28 and 30 weeks of gestation. She has preeclampsia, blood pressure is 180, 120 with a rupture of membranes. Again, here the therapy is really going to be dictated by the preeclampsia, which is going to take precedence over PPROM, or whether the fact that there has been an adequate time for steroids to act, because now at a blood pressure of 180, 120, which has not been controlled with antihypertensives, my priority is to keep the mother safe. So I think this is a patient who is headed rapidly towards delivery. Dr. Nilusha, hello there. Hi Nilusha, Mumbai. If the patient has taken steroid cover at 32 weeks, presence with rupture at 36 weeks, are we supposed to repeat the steroid dose? No, not really, because she's way beyond the 34-week mark. Nilusha, no need. You can just go ahead with delivering her. Betamethasone or Dexa, I think I answered that. Sham asked me, in multifetal gestation, prophylactic cervical cerclage, is it recommended? The answer is a clear-cut no, not recommended at all. That's not the correct practice that one should follow. Dr. Archana from Gautam Budh Nagar, 22 weeks twin pregnancy with leaking and cervical ballooning. Role of an emergency cerclage. Absolutely not, Dr. Archana. Please don't attempt this. It will be a failed exercise. In fact, you will be putting this woman through an unnecessary operative procedure, and the fact that a cerclage is there will add to her risk of sepsis. Dr. Dinesh Zinzala from Bhavnagar, role of tablet betamethasone, well, no, not really. Please do not use oral steroids in this kind of a situation. Please use injectable steroids only because they have a much better transplacental passage and they are known to be more effective than oral steroids to induce the fetal maturity. I think that's the end of the questions. And once again, I thank you from the bottom of my heart for this really interesting and interactive session on preterm pre-labor rupture of membranes. Thanks for logging in. It's been a wonderful session that we've had. And I hope I've been able to answer most of the questions that have come up satisfactorily.